When there is neglect in treatment, I again call it a neglected fracture. One is the late or it may cut through. So this is neglecting treatment. I again define it as a neglected fracture. The various problems could be that the neck is absorbed, as you find here. There can be coxa vara, neck shaft angle is reduced, trochanter has gone up. There can be external rotation deformity of the lower limb. Again, you find in this slide, the coxa vara, the trochanter has gone up, and there is shortening of the lower limb. Obviously, you can anticipate. Another problem is this: when neglect becomes chronic, as you find here, this is an extracapsular fracture of long duration. Patient is walking, there may be another fracture of the neck of the femur. So two fractures. One is trochanteric fracture, other is fracture neck of the femur in the same patient, indicated by the arrows. Here it becomes very obvious because pain becomes more to this patient, and there is more of antalgic gait and lurch as well. One can confirm that a second fracture has occurred on CT scan sections as well as 3D reconstruction. So here again you find when metal breaks, so management becomes difficult because removal of the metal is essential to preserve his hip. I don't answer THR in a young adult patient. I'm just advising my postgraduate residents that most of them are now well versed with THR being taken up in various hospitals, particularly corporate sectors. So when the patient is young adult, your answer must be hip preservation. Here the screws are broken, so one has to remove the screws, and that is again a challenge when you design or define the management of such a patient. So here arrow shows you the broken screw, and there is coxa vara also in this patient. This is another problem you find here. Because of the movements of the screw in the head of the femur, there is bone loss, which is again shown to you by these yellow arrows. So once there is bone loss, stability is a very, very difficult question in these cases. You have to preserve the bone. You have to add some bone here to give stability, like fibula or cancellous bone. Only then you can preserve such a hip in a young girl. This girl is only just 21 years old. There is only one classification on neglected fracture neck of femur, and that's also from India, type 1 or group 2 and group 3. When the fracture gap is less than 1 centimeter or head is viable, it is group 1. When the fracture gap is between 1 to 2.5 centimeter, when the gap is more than 2.5 centimeter at the fracture site, I showed you absorption at the fracture site, or there is avascular necrosis, it is group 3. The objective is to achieve pain-free, stable, mobile hip that heals with a vascular head, limb length equalization, and patient should have normal or near normal gait. That's the objective, and that's very important. And that is what you should aim for. Now, closed reduction or open reduction with internal fixation alone, shortening is less than 1.5 centimeter, and femoral head is viable. I'm telling you of the few methods. More than closed reduction may be difficult. Presence of osteopenia or bone loss when the head is small or there is varus angulation outcome is unfavorable with osteosynthesis alone, so you have to devise some other method. Now, in this country, and even now internationally, fibular autograft with lag screw fixation has become also prominent. There are papers from India by Nagi et al., Professor Yadav, and so many other authors. Union rate is 91 to 95%. It's a biological method. But the problem is of coxa vara. Still, you can find coxa vara in 28% of the patients. There is leg length discrepancy up to 5 centimeter. And again, there is a donor site morbidity. The limb from where you take the fibula, you have to give second in CN, and there is morbidity. That is why we say that think of the method which corrects coxa vara, which gives you neck shaft angle, which gives you limb length equalization. In type 3 Sandhu's classification, which I just mentioned, where the fracture gap is more than 2.5 centimeter, or there is avascular necrosis, the failure rate is 67%. So again, this method will not apply to all these patients in group 3. Now, most of the people again still doing this country Maya procedure. The problem is again that union can be achieved in 75% of the patients, but still there is a problem of coxa vara. There is shortening, and limb length discrepancy is there because you, whatever position you have gained on the fracture table, and you have put in your quadratus femoris graft, coxa vara will remain there or will reoccur. Union is 100% when you use vascular fibular graft, but it's a time-consuming procedure. Takes 7 or 8 hours, even 10 hours, and this needs microsurgical facilities, and it is not everybody's cup of tea. You have to have vascular surgeon with you. So this method is not applicable in everybody's hand. Osteotomy have now become popular, I should say. Most of the people, surgeons have started doing. There are a lot of papers now in the literature also. 3 osteotomies I have described. McMurray osteotomy still being done in this country. Shane's osteotomy still being done in this country. Powell osteotomy now replacing these 2 procedures. Powell osteotomy is becoming very popular. This is McMurray's osteotomy. It's a medial displacement intertrochanteric osteotomy, the arrow shows. Medial displacement, this is a medial displacement indicated by yellow arrows. Intertrochanteric pelvic support osteotomy. This is, if you define it, if the examiner asks you what is McMurray's osteotomy, it's a medial displacement intertrochanteric oblique osteotomy. The weight bearings from sacroiliac joint, because fulcrum is broken to the head, and then directly to the distal fragment. It gives you an armchair type of effect. This is the armchair. If you sit in the chair which has arms, you will not fall. So it is a pelvic support osteotomy. The weight bearing is directly from the sacroiliac joint to the head and then to the distal fragment. But the side effect is that when you translate the femur medially, you see here, the mechanical axis passes laterally, and this results in genu valgum shortening. The disadvantage of McMurray osteotomy is there is shortening of the limb and genu valgum in the long run. So this is a Shane's osteotomy. It is an angular type of osteotomy. McMurray osteotomy is a translation type of osteotomy, but Shane's osteotomy is an angular osteotomy. This is performed at the level of the ischial tuberosity. The distal fragment is abducted. Shane used to give hip spica, but these days we are having contoured plates, or you can contour the plate yourself. The line of weight bearing is very interesting from the side of the pelvis to the proximal fragment and then the femur. McMurray osteotomy, armchair effect, pelvic osteotomy, but this is a angular osteotomy, and the line of weight bearing is from the side of the pelvis to the proximal fragment directly. Again, there is medialization, and genu valgum occurs in these patients also. So if somebody asks you the complications of McMurray osteotomy, Genu valgum, shortening. Complication of Schanz osteotomy, again you can say genu valgum in all these patients. Powell said that if you place the fracture surface at right angle to the resultant of body weight forces, the fracture line is compressed. This is conducive to healing and the fracture heals. That's the principle. He too used to give spica. See, fragment is displaced medially under the fracture end. So this too resulted in shortening and stiffness because of hip spica. So now we have better implants, particularly the double angle blade plate or a double angle barrel and DHS plate. You can even use DHS plate. That depends upon your skill. So if you use a double angle barrel plate, some stabilizing implant, when you use it, this medialization can be prevented and genu valgum can be prevented. Limb length equalization can be achieved. That is the beauty of this osteotomy, and that's why the two other osteotomies have always been almost been replaced by Powell's osteotomy. So here you find this is 45 degree. We have converted into 25 degree, and this becomes at right angle to the resultant body weight forces, and coxa vara is corrected, and it is conducive for healing. So this corrects coxa vara, this corrects rotational deformities, and a very common movement for all we people, Asians and Indians and third world countries. Patient may be able to squat and sit cross-legged. That is what is the requirement of we people in cases of hip disorders. And if this is a shortening A, the coxa vara you see, the trochanter has gone up, you have to bring it to the center of the level of the head of the femur. This has gone down. So if this is the shortening, A is the shortening, so A plus B is the gain in length by a Powell's osteotomy. That's the beauty of this osteotomy, that limb length equalization can be achieved. The two options are left now. THR for elderly people. When a case comes to you, Dr. Mani was telling you that 2 or 3 candidates are given hip cases. And one of them can be fracture neck of femur. If this case is already there in the ward. So your answer in a young adult patient should be, sir, I will preserve the hip. And in a neglected case, the best answer, you can say biological method, say, even you can say, sir, fibrografting. If neck shaft angle is good, you can fix with a screw and put a fibula. But if neck shaft angle is less, you have to correct the coxa vara also. You think of osteotomy and say answer osteotomy, you will never fail, I can tell you. Surgical technique is very easy. I'm just passing through. Patient maybe on fracture table, but I do it on convention table. So patient on the convention table, just 5 centimeter incision. This is the fascia lata. Pass a guide wire. Stabilize the proximal fragment, that is the head fragment with a screw. Because if you pass the blade or the chisel directly, then this head will rotate or wobble. So fix the head with a screw, first with 2K wires or guide wires, then with screw, and now you make a track. And I tell you, for this osteotomy, not much of planning is required. Just excise a wedge of 20 to 30 degree between the two trochanters, greater trochanter and the lesser trochanter. From here, about 15 millimeter distal to the entry of the chisel, because that is the bone block which gives you stability. So see the passage of the chisel both in AP view and in lateral view. That is not difficult to make. This is the frog leg view or the frog leg view. This is the image intensifier, and you just flex it by 40 degree and then externally rotate it and take an AP view. You will see the chisel is in the center of the neck of the femur. It's very important. It may go anteriorly or posteriorly. So must have an AP view and a lateral or a frog leg view. So now you have made a track. Divide the vastus latalis, 2/3 anteriorly, 1/3 posteriorly. And here you are elevating the muscle, but don't disturb the periosteum. And here you have excised the wedge. Distal is in situ. You may use an oscillating saw, or you can also use an osteotome. This is the saw. You can use good chisel also. And the angle between the plate and the femur, just remember it, must be equal to the wedge you have excised. If you have excised a wedge of 30 degree, this angle should be 30 degree between the plate and the femur. And here you have introduced the chisel, and here you have done the fixation. Trochanter has gone down. The good thing is this, that we have not divided the capsule. Approach is Watson-Jones approach. Entry, the track is made, and just push the chisel and the blade after that, and do the osteotomy and abduct the distal fragment, fix it with the screws. So biology is kept intact, capsule is not divided, and this gap will heal. So this is one case of macroneal osteotomy on one side. This is valgus osteotomy on the other side. This osteotomy was done by my boss 40 years back, and this is a 39 years follow-up, and this is 20 years, 5 months follow-up osteotomy done by me in this institution at Rohtak. Now I'm at Max Saqib. And this problem, again, I told you, difficult one, because patient may be just 30, 35 years, totally again not the answer. So you will say, sir, I will remove the implant and I'll preserve the hip, and better method could be an osteotomy or a fibrogram, whatever you think, like, depending upon a particular situation or a particular case which you have seen on examination and taken a history also. So remove the implant, and I have done an osteotomy in this case. I'm not going in detail how did I remove the implant, because that is not your cup of tea. I'm just teaching the methods, narrating the methods, and telling you what are the best procedure in a young adult. So here it is just fixation with the K wire. I have removed the implant and I have done the osteotomy. The same way I have described you, that is a track with chisel, and that is the plate, that is the plate, and that is the wedge I have excised, and this is what you see, the fixation. This is the follow-up at 56 weeks, and patient can squat. You see he's just 35 years male. Don't say, sir, I will do THR. Say, I'll preserve the hip in a young adult. Here, the screws are broken. It's a difficult situation. I'm not going in detail. So if you do Powell's intertrochanteric osteotomy, the highest rate, the union is 92%. Literature says this is between 80% to 94%. Non-union still can occur because of infection, because of implant cut through, because of other reasons. But there is good rate of union if you perform a Powell osteotomy. If you perform a macroneal osteotomy, union may not occur. Patient can still walk because of the armchair effect. That is again important point you must keep in mind when you are appearing your examination and going through your viva voce. Limb length equalization can be achieved again. Average shortening in my series is 2 centimeters still, because it was excessive to begin with, 5-6 centimeter. Neck shaft angle you can almost equalize, and coxa vara can be corrected. So some of the result of valgus osteotomy by various authors from this country, like Kalra, Sringari, and my series, and so many other authors by other biological methods like the muscle pedicle bone graft. You see, Bakshi is the pioneer in this country. Now, so many people are doing, but there is only one paper as far as the indexed international journal is concerned on Myers procedure. That is one only in 1945. There is no other paper on this procedure in the international journals. Powell osteotomy getting more and more popular for the reason which I have just narrated you and briefed you. So this is a case of, I even do in elderly people. This is just 73 years female, because now I have achieved skill. But in an examination, if patient is 73, just say, sir, I will do arthroplasty of any type. Even if you ask, sir, I will do Gurdle stone in a 73, the examiner will be very happy that at least you know the principles. In a young adult, you preserve the hip. In elderly people, you do arthroplasty. So here this result 25 weeks in this lady, 8-year follow-up, just telling you that this is a wonderful procedure, and you see how comfortable this lady is sitting, squatting on toes. This is just finishing Just finishing my first case, 1990. See the follow-up published in Journal of the Trauma, 24 years follow-up. Now, this is a 10 years when she was studying for a master's degree. Now she's 33-year-old, 24 years follow-up. And last month, this is 30 years follow-up. Mild OA changes, and she walks beautifully with no limp. I have made all these lines to draw the various angles, neck shut angle, neck length, and all those things. Just for your understanding, I can have a longer seminar. Even if there is avascular necrosis, it is a biological procedure. And if head is rounded, you can go for this osteotomy. Provided there is no collapse, head has maintained its shape. It is non-union of 18 months duration. It's beautiful. The patient is still working very well after 11 years of follow-up. And I have shown these cases all over the world and can squat.
Dr. Magu, please summarize.
Now I'm summarizing and just telling osteotomy is a simple procedure, cost-effective, can be performed in a convention center. Union rate is 100% of osteotomy. Be clear, osteotomy unites 100%. Limp is not always the phenomena. And if it fails, as in this case, 1998, THR can still be done. He was 70 years male, suffering from Parkinsonism. So THR can still be done. So surgical know-how of osteotomy is in danger and being lost. And I have taught you the principles, the various papers. Thank you very much.
Thank you.